Hi, and welcome to today's episode of OBGY Nuggets. I am Dr. Aditya Nimbkar, and today I'm going to give you a nugget on injection anti-D. This is a topic that we probably we probably get in touch with every week, but there are a few concepts that are still confusing. And today, in the next 5 to 6 minutes, I ensure that I'll be revising all of them for you. The guideline that I'll be using today is BCHS. This is a guideline that is used by the RCOG, and it is the guideline that will tell us on when, for whom, how much, and why should I be giving anti-D to any female who's pregnant. So, the first thing that I'll be talking of today is going to be what are the patients and who are the ones who are candidates for receiving this injection. So, the first thing that I'll be doing is I'll be dividing this pregnancy into three halves, rather into three parts. It is the first trimester, then there is a second trimester, and there is a third trimester, along with which I have also clubbed the postpartum period. So in the first trimester, often women present to us with bleeding per vaginum, which we call as threatened abortion. A few females also complain that they are also experiencing excruciating pain. Technically, these are the candidates who should be given anti-D prophylaxis because when there is pain, there is uterine contraction, and that uterine contraction leads to isosensitization. It leads to sensitization, which leads to isoimmunization. So these are the patients who should be definitely getting anti-D vaccination in comparison to the ones who are not having pain, are only passing clots and blood. Apart from that, molar pregnancy. Now, this is a topic of confusion for many. The blanket statement that I'd like to give you is give anti-D to all patients who have had molar pregnancy. Why is that so? Yes, complete mole, it has those chorionic villi, it has trophoblastic hyperplasia, but none of these tissues express the rhesus antigen. But whereas in a partial mole, there is a component of fetus, and that is the one which also has blood cells, red blood cells, and also something that expresses Rh antigen. Now, to differentiate between a complete and a partial mole, you need a histopathological report, and your histopathological report is not going to arrive for the next 2 to 3 days at least. It takes at least that much of period to arrive for it to arrive. And we also know that the golden period for administration of anti-D injection are the first 72 hours. And if it is given after that, the efficacy just goes down significantly, drastically. And hence, as a blanket thing, we just give it to everyone because we can't be waiting upon for a report to come and to tell me whether there was complete or partial mole. And also, there is no harm in giving anti-D. It has hardly got any side effects. Then why not just give it and save the woman in the next pregnancy from getting isoimmunization? The next one is ectopic pregnancy. Again, a topic of contention. Again, a blanket statement. You have an ectopic pregnancy, just give her anti-D. Well, the guidelines say that for all surgically managed ectopic pregnancies, it can be through salpingectomy or salpingostomy. It can be whether it is done by exploratory laparotomy or laparoscopy, have to be given injection anti-D, period. But for patients who are managed on medical ways by giving methotrexate are the ones who are the, I believe, is what the point of contention is over here. But despite all the controversies, again, there is no harm in giving anti-D. And hence, to these patients as well, just give them anti-D. There's no harm in giving them, but there definitely is harm if you don't give it to them. The next is MTP, medical termination of pregnancy. So all the pregnancies that are terminated by surgical evacuation, it can be in the form of a curettage, it can be in the form of suction evacuation. These are the candidates who should definitely be receiving anti-D. Whereas patients who are given medical abortion through just mifepristone and misoprostol and are not given any surgical methods to abort, they are not candidates. They should not receive anti-D vaccination. The next is when we come to the second trimester, in that we perform a few procedures which include they are diagnostic procedures that we do, that is chorionic villus sampling or amniocentesis. These again are events in which there is feto-maternal hemorrhage that happens, and again these are candidates for receiving anti-D injection. Next, bleeding per vaginum patients. Again, now here, irrespective of the pain, they should be receiving anti-D. Also, if the bleeding continues for a prolonged period of time and the pregnancy also continues, fortunately for that female, then every 6 weeks you have to repeat the vaccination, because after all, this anti-D is passive immunization. Once you give it in the body is going to lyse it. It is going to break down those antibodies over a period of time. And that period is going to be 6 weeks. So this vaccination, or rather this immunization, has to be repeated every 6 weeks if the bleeding continues. Finally, our AADP, something that we all know, routine antenatal anti-D prophylaxis. So the vaccination that we give to all our Rh negative females at 28 weeks is known as our AADP. It has got a very good name, and it'll look really good if you're going to be calling this as our AADP next time onwards amongst your peers. Now, obviously, how do we give it? First, we test the indirect Coombs test for the female at 12 weeks. If it is negative, then we repeat it at 28 weeks. If it is again negative, obviously, if the husband's blood group is positive, then we give this female a shot of anti-D. In the third trimester, if there is any abdominal trauma, if the female has suffered a fall on her abdomen, or if there has been a physical altercation, if there has been a physical assault in which she has suffered a hit on her abdomen, definitely there is going to be fetal-maternal hemorrhage, give her anti-D. ECV, external cephalic version, something that we do to convert a breech or transverse lie into cephal so that she can probably have a greater chance of delivering vaginally. Again, fetal-maternal hemorrhage is very likely. Cover it with anti-D after you're done with the procedure. Finally, post delivery. Obviously, you check the baby's blood group. If the baby's blood group is positive, give the mother anti-D. After all this, you would be thinking, what is the dose in which I should be giving? Well, the doses are well defined. If your pregnancy has any event that has occurred before 20 weeks, then we should be giving 250 international units, whereas after 20 weeks, it is 1,500 international units. But we don't really use international units in our country. Also, the vials that we get mention the dose in the form of microgram. So, to talk in terms of microgram, before 20 weeks, give them 50 micrograms, whereas after 20 weeks and post delivery, obviously, give them 300 micrograms. So, the RADP, the routine antenatal anti-D prophylaxis that we give at 20 weeks, as well as the postpartum injection that we give to all our females who are Rh negative, the dose is going to be 300 microgram. Again, a controversial point is often in a lot of institutions in the first trimester, if there is any event, they give doses of either 150 microgram or the complete 300 microgram. Well, the thing over here is if you're going to be getting a bottle, a vial of 300 microgram, and if you're going to be giving just one fifth to the female, then the remaining part in that vial is going to be wasted. So instead of wasting it, it's an expensive injection. A lot of people just end up giving either 150 microgram or directly the entire dose of 300 microgram. It doesn't matter. But the guidelines say that it has to be 50 microgram and 300 microgram respectively before and after 20 weeks. If we are going to detail in a little more, which we have done on our app on Conceptual OBG, the actual dose on how much should be given over this dose is calculated by the KB, the Kleehor-Betke test, which tells that how much of fetal-maternal hemorrhage has occurred. That's a very lengthy discussion on how do we calculate it, how do we test, kitna hua hai hum log ki is fetal-maternal hemorrhage. That is something that we have discussed on the application, and you will find us talking about this there. This is Dr. Aditya signing off from this OBGYN Nugget on anti-D. Hope you liked it. Do comment what are the topics that really confuse you all in your clinical practice during your residency. We would love to do sessions on them. Thank you.